Hello, my name is Áine Carroll and I am Professor of Healthcare Integration and Improvement at UCD, and I'm also a consultant in rehabilitation medicine at the National Rehabilitation University Hospital. It is a very great pleasure for me to be here today to share with you some thoughts that we have around implementation of road safety strategy in Ireland, a serious injury and rehabilitation perspective. So what I'm hoping to cover today are a few things. Why thinking about serious injury is important, why thinking about systems is important. I'd like to share with you the experience of the National Rehabilitation University Hospital over a 5-year period. And also I'd like to share with you what I believe that we can and indeed must do about it. So why is this stuff important? I think it's important to remember that globally, road traffic collisions are a leading cause of death and serious injury, with over 1 million people dying every year and 20 to 50 million surviving with serious injury and disability. And yet, despite overwhelming evidence of the devastating health and socioeconomic consequences of road traffic collisions, until recently their impact has been essentially neglected by many government services and policy, particularly in low and middle income countries. But thankfully, that hasn't been the case in Ireland. And as we know, there has been a significant change in the road safety landscape in Ireland over the last 25 years. In 1998, the first government strategy for road safety was published, followed by the establishment of the Road Safety Authority in 2006 as a statutory organisation created by the Road Safety Authority Act 2006, with the specific aims to reduce collisions, deaths and injuries. And from 2012 to 2019, Ireland improved from 5th lowest to 2nd lowest country for road fatalities per million population within the EU 28. And indeed, they were awarded the prestigious ETSC Road Safety Performance Index Award in 2019 in recognition of this. And when in the new strategy, in the new report, we can see that there were 136 road deaths in 2021. And while we might feel that that's too many, it's still a significant improvement. So we've achieved a great deal in a relatively short period of time. And it's a great welcome thing to see the new strategy being published. So the aim is to reduce the number of deaths and serious injuries on Irish roads by 50% over the next 10 years. So this means reducing deaths on Ireland's roads annually from 144 to 72 or lower, and reducing serious injuries from 1,259 to 630 or lower by 2030. And this is the first step in achieving the 2020 programme for government commitment of bringing Ireland to Vision Zero. So that's to eliminate all road deaths and serious injuries on Irish roads by the year 2050. So that is incredibly ambitious. But I think it's important to be ambitious when we're thinking about strategy and the implementation of strategy, especially in Ireland. So I'd like to share with you another few significant developments that there have been over the last short number of years. So a very significant development has been the National Office of Clinical Audit, NOCA, implementation of the Major Trauma Audit in Ireland. Data collection commenced in 2013, and most trauma-receiving hospitals are required to submit trauma data. However, although in the UK, TARN has been linked to the UK Rehabilitation Outcomes Collaborative, in the National Clinical Audit of Specialist Rehabilitation following major injury, in Ireland thus far, we do not have a Rehabilitation Outcomes Collaborative, and therefore we have very little information about the rehabilitation needs of patients leaving the trauma-receiving hospitals, or indeed how well these needs are being met. And there are also many other sources of trauma and road traffic related data in Ireland, including the Irish Hip Fracture Database, the Irish Longitudinal Study on Ageing, the Road Safety Authority, the Health and Safety Authority, the Central Statistics Office, and the Hospital Inpatient Inquiry System, etc. So as you can see, the data landscape is complex. So if you think about all the different agencies and organisations that are involved in trauma, and think about all the different teams and all the individuals right across the continuum of care, from prevention to long-term care, I'm sure you would agree that the trauma landscape is very complex. And then if you superimpose all the different data systems, all the different outcome measures, all the different measures that are being measured, I'm sure you would also agree that the data landscape is just as complex. So just to touch on complexity a little bit, because that's one of my big interests. And before I scare you off completely, complexity science is simply the study of living systems. And there are two major subfields in the theories of complexity. That's complex physical systems and complex adaptive systems. And complex adaptive systems refers to complex systems where agents learn and adapt in response to interactions with other agents. And the use of complexity theory is increasingly being embraced in healthcare, although as Trish Greenhalgh and colleagues note, we embrace the theme of complexity in name only, and we fail to engage with its underlying logic. So when you look at this map of complexity science, and I'm extremely grateful to Brian Castellani and colleagues for allowing me to use this slide, but they have saved me a great deal of time in doing the hard work for me. So even the area, a whole area of complexity science is in itself complex, and perhaps we shouldn't be surprised. So if you think about the underlying features of a complex adaptive system, and you look at how the trauma ecosystem compares, the underlying features of a complex adaptive system are that they are constituted relationally, they have adaptive capacities, that they involve dynamic processes, that they are radically open, that they are contextually determined, and that novel qualities emerge through complex causality. A trauma ecosystem meets all of those characteristics and features. So therefore, I would argue a trauma ecosystem is a complex adaptive system. And if you're interested in reading a bit more about that, I published a paper on the Irish healthcare system as a complex adaptive system last year in the Irish Medical Journal. So I've left the citation there if you're interested in learning more about that. So the next important development is the trauma system for Ireland. And they acknowledge that there is a need for better data and access to data across the continuum of care. But it's also really important from a rehabilitation point of view, because if, as in other jurisdictions, there is an improvement of between 15 to 20% in survival, then the demand for rehabilitation will also increase. And as we have challenges for our current numbers of trauma patients accessing appropriate rehabilitation, that demand is only going to increase. And we're very good in Ireland at developing policy and strategy. We're just not quite so good at implementing that policy and strategy. And it's also really important, if we think of the trauma ecosystem as a complex adaptive system, we have got to get better at implementation. So in other research that I've done studying the health ecosystem, the biggest challenge that we have in Ireland is the transfer of innovation and disruptive innovation and diffusion of innovation into operations. So our organizations do not seem to realize that you require organizational ambidexterity. So what does that mean? That we need to do the job, but we also need to be innovative and improve the job. And that is the biggest barrier to implementation in the Irish system. And when you look at the trauma strategy, it lays things out in a very linear fashion. Whereas if we accept that the trauma ecosystem is a complex adaptive system, then we need to appreciate that these are all different elements that are working together. They're shifting, they're changing, they're adapting, they're responding. It's very dynamic, whereas this presents things as being very linear and indeed you could argue reductionist. We need to be able to look at our trauma ecosystem as a complex adaptive system. And of course, key to that is access to good quality data. So do we currently have access to good quality data across the continuum of care? The answer is unfortunately, we don't. And if you also look in terms of integrated care, then my colleagues in the International Foundation for Integrated Care have really emphasized the need for us to be thinking about data. Data sharing of information, transparency of progress, results and impact. That is recognized as one of the foundational pillars upon which integrated care is built. And as my friend and colleague Nick Goodwin said, the role of information, communication and technology is commonly regarded as one of the essential ingredients in enabling the success of integrated care. It has the most uncommon dual property in this regard. It is simultaneously the grease that allows integrated care systems to operate as smoothly as they can through good communication of information between care professionals and service users, but it's also the glue that binds care systems together. And again, I've given you the citation so that you can have a look at that paper. So essentially, data is the glue and the grease that holds everything together and allows things to move smoothly. So one of the first pieces of work that I did was to conduct a literature review to see how had people studied the implementation of road safety and trauma strategies. And I identified several recent systematic reviews and meta-analyses exploring the impact of trauma systems on injury outcomes. And as I expected, most studies looked at mortality as the primary outcome measure. And as many systematic reviews do, they recommended further research. However, they did recommend further research to properly evaluate the different components of trauma systems and non-fatal outcomes and explore the impact of system component interactions. So you can see that dynamic, complex adaptive system requirement in terms of our thinking about the trauma ecosystem. And although there are many publications and empirical studies that look at the impact of elements of road safety strategy, there were none that evaluated implementation of road safety strategy as a complex intervention in a complex system. And most publications agreed on the need for further research exploring long-term and patient-centered outcomes. So you can see that there are lots of different pieces to this complex jigsaw, but a very important part of that jigsaw is data and information sharing. So it's really important that we get the data piece right. So in the absence of an Irish Rehabilitation Outcomes Collaborative, we decided that we would undertake a review to see if the presentations at the National Rehabilitation University Hospital of road traffic trauma-related injury had changed, with a research question, how have admissions with road traffic-related injuries changed over the last 5 years? The aims of the study were to investigate the types of injuries sustained in road traffic collisions in patients admitted to the hospital over a 5-year period from 2014 to 2018. And we wanted to identify the types of road traffic collision-related injury, determine if the numbers of admissions had changed over time, and also determine if the numbers reflect the implementation of road safety and trauma strategy. So for those of you that aren't familiar with the National Rehabilitation Hospital, it is the only hospital in the Republic of Ireland that provides complex specialist rehabilitation services to patients who have a complex acquired disability because of an accident, illness, or injury. Specialist rehabilitation is the total active care of patients with complex disabilities by a multi-professional team who have undergone recognised specialist training in rehabilitation, led or supported by a consultant trained and accredited in rehabilitation medicine. The National Rehabilitation Hospital serves the whole national population, and rehabilitation programmes are tailored to meet the individual needs of adult and paediatric patients in the following areas of specialty: acquired brain injury, stroke specialty programme, the spinal cord system of care, prosthetic, orthotic and limb absence rehabilitation, and paediatric family-centred rehabilitation. It is fully publicly funded and is a tertiary referral hospital, and it is accredited by the Commission for Accreditation of Rehabilitation Facilities. And although we collect a broad range of data, the national data standard is the Hospital Inpatient Inquiry, and that is the principal source of national data on discharges from acute hospitals in Ireland, and uses the clinical coding scheme, the International Classification of Diseases, or ICD-10. So our methods were a retrospective review of healthcare records, and we looked at all patients discharged from the inpatient rehabilitation service with an ICD-10 coded diagnosis of transport accidents from 2014 to 2018. Our data source were the NRH interdisciplinary healthcare record, and data extraction was performed in accordance with recommended best practice for the performance of retrospective chart review and medical record abstraction. Data analysis was conducted using SPSS version 27, and chi-squared was used to determine whether there was any association between injury type and demographics of the patients. We used convenience sampling with all cases selected over a defined period of time, and a simple coding manual was created. We adopted 9 as a universal code for missing data as recommended by the HSE healthcare audit criteria and guidance. Inclusion criteria included first admission unless the individual had a subsequent road traffic collision, and they had to be admitted between January 2014 and December 2018. Exclusion criteria included readmissions due to the same road traffic collision or an admission date before or after the beginning and end points. Specific data gathered included age at presentation, gender, clinical programme, level of disability as measured by the modified Bartel index, and the year of admission. And in addition, the number of road traffic collision related severe TBIs, spinal cord injuries and traumatic amputations were extracted from the major trauma audit reports from 2014 to 2018. Results. We identified 338 cases. 178 of these did not meet the inclusion criteria because of readmissions due to the sequelae of the same road traffic collision, and one chart had been miscoded. So the total number of healthcare records that were analysed systematically using a standardised data extraction proforma was 165. So results, figure 1, number of admissions. And I'd just like you to have a look at this slide for a couple of seconds. And I'm going to ask you the question, what does that slide tell you? And I'm going to come back and I'm going to show you the data in a slightly different way in a few slides time. But I want you to think about, what do you think the story of that slide is? So age distribution, 72% were under the age of 40. And from a gender point of view, 73% were male and 27% were female. In terms of type of injury, 77% had traumatic brain injuries, 20% had traumatic spinal cord injuries, and 3% had traumatic amputations, and there were no combined injuries. Chi-squared test revealed there was no significant association between injury type and gender categories. In addition, brain injury was a major type of injury for all age categories. And also chi-squared revealed that there was no significant association between injury type and age categories. So you're probably looking at this and thinking, what is going on here? Well, when you look at data in terms of data for improvement, there are different analysis techniques that you can use which allow your data to tell a meaningful story at a glance. So I was introduced to these techniques when I was doing my quality improvement training, initially through the Royal College of Physicians of Ireland and HSE Quality Improvement Division. So my sincere thanks to Dr. Philip Coley and colleagues for opening my eyes to the importance of data for improvement. So when you look at data for improvement, you look at your data using particular types of statistical analysis, and you're looking for certain rules that will tell you whether variation is non-random. So you're looking for shifts, you're looking for trends, you're looking for astronomical points. So you're looking for specific things that tell you whether your data is either randomly distributed or non-randomly distributed. So when we take a look at the data that I presented in the first slide of the results, when you look at it through a statistical process control chart, it really helps us to understand what is different and what is the norm. So when we look at the admissions now through that lens, we can see that there's no data point breaching the upper control limit or the lower control limit. There's no clumping of the results to either side of the mean. So that can tell us that actually this is normal distribution. So there hasn't been anything of interest that has really happened. For example, an intervention that has a dramatic impact on admissions. So we would have to look at this data and think, it wouldn't appear that there's been anything dramatic that has happened in terms of interventions or implementation of strategy or policy that has made an impact on the admissions to the National Rehabilitation Hospital. So it really helps you to understand your data in a much more meaningful way. So we know that all patients with traumatic brain injury had a moderate to severe acquired disability on admission. And that's what we would expect because we're a complex specialist rehabilitation hospital. However, the level of disability for the other programs was incomplete, so therefore we had to exclude it from analysis. When we analysed the major trauma audit reports, the reports only detailed road traffic collision related severe traumatic brain injury, as defined as a Glasgow Coma scale less than 9 or 8, depending on the report. And road traffic collision related traumatic spinal cord injury and amputation numbers were not stated. In the 2016 report, the Glasgow Outcome Scale, which is a global scale for functional outcome, on discharge was reported, but it did not specifically look at road traffic collision related injury. So as we could not derive road traffic collision related information from the disability measures, we decided that we would look at road traffic collision related severe traumatic brain injury. And this is what we found. So the blue line at the top is the data from the major trauma audit. And then the data at the bottom is the data that we've looked at already, the admissions to the National Rehabilitation Hospital. So although these measures are slightly different, the blue line tells us that there was quite a number of individuals with severe traumatic brain injury. And you would expect that most of those would require access to specialist rehabilitation. but we can see that there is a gap because the numbers across the bottom are the numbers that were actually admitted. So I think this tells us enough that this is maybe something we want to look more closely at, that we need to examine the data in more detail. And then when you look at height data, I pulled the data, and my sincere thanks to Rory O'Reilly from the Healthcare Pricing Office in the HSE for providing this data. You can see that there are very large numbers of individuals that are admitted over the same time period. So really what I'm trying to tell you in these different slides is that we have got all these wonderful sources of different types of data, but we're not necessarily talking about the same thing. So we are looking at different parts of the elephant, if you like. So we know that the major trauma audits focus on more severely injured trauma patients, those who have potentially life-changing or life-threatening injuries. And we know that most hospitals report data, but we also know that not all data is complete. So I think we need to ask ourselves, do we have an agreed definition of trauma right across that continuum of care? Because even the word trauma means different things to different people. Do we agree on what is a serious injury? Do we understand fully what is important to all the different stakeholders across the continuum of care? And do we recognise the need to be monitoring long-term outcomes long-term? So in summary, analysis of the data of inpatient admissions to a complex specialist rehabilitation hospital showed that the road traffic collision-related injuries were commoner in younger males, and this is keeping with many other reports, including the findings of the major trauma audits. The most common injury was traumatic brain injury, followed by traumatic spinal cord injury. At first glance, it would appear that there was an overall reduction in road traffic collision-related injuries over the 5 years studied. However, when you analyse that through a statistical control chart, this is normal variation with no special cause variation. However, we only have 5 data points, and it could be that the impact of implementation of any strategy or policy takes longer before a clear change becomes apparent. So we therefore plan to prospectively track road traffic collision and trauma-related admissions on an annual basis and report back to the Trauma Lead and the Road Safety Authority. Also, I acknowledge that this is a one-centre study. However, the National Rehabilitation Hospital is the only complex specialist rehabilitation hospital in the country, so we should be receiving all trauma cases that result in complex disability. So we also recognise that rehabilitation services are the missing link between hospital and community services. But traditionally, these have been seen as a nice to have rather than an absolutely essential component of a trauma system of care. However, integration of rehabilitation services into the continuum of care within and beyond acute hospitals, we know, will accelerate discharge, will reduce disability and reduce costs of care. So frankly, they're a no-brainer, folks. And as stated in the trauma report, a strong focus on comprehensive patient-centred rehabilitation services is required, with early assessment of rehabilitation need, as well as enhanced hyperacute, acute, post-acute, regional and community rehabilitation services to enable patients to achieve their maximum functional potential. Key to an effective trauma system is excellent knowledge mobilisation, enabling research, care management and performance improvement. However, as has been shown by this study, although there are a number of existing databases and information management systems along the trauma pathway, they are fragmented, they speak different languages from a data point of view, and there are significant gaps, particularly from a rehabilitation point of view. In order for us to understand the impact of any road safety strategy or implementation of the trauma report, addressing this fragmentation and plugging these knowledge gaps are essential if we are to successfully evaluate our services across the continuum of care. So in conclusion, ultimately, the evaluation of the success of any road safety or trauma policy will be dependent on the quality of the underlying data that reflects the continuum of care of people surviving with life-altering injuries. There is much work to be done in making this a reality. All agencies, and most importantly, people affected by road trauma, need to agree and have a shared understanding of what data should be collected across the continuum of care. Data linkage between administrative and health data sets does not currently exist, but offers huge potential for understanding the trauma and rehabilitation ecosystem in detail. So what can or indeed should we do? Well, I believe that we should have a tilde for trauma. We need to invest in the necessary comprehensive data sets across the continuum and really invest in that data collection and look at long-term outcomes. We need our data to tell a comprehensive story. We need data linkage. We need appropriate analysis methods. We need access to appropriate expertise. So where are our social scientists, our clinical expertise, our individuals with lived experience, engineers, legal, et cetera, and we need to take a partnership approach. We need to take an evaluation approach that is developmental, so that is continuous collection, analysis, and feedback. It's not good enough to wait for annual reviews. We need to be collecting data in real time and feeding that into the trauma ecosystem. We need to apply complexity theory to the trauma ecosystem. And lastly, we need to invest in rehabilitation. And I believe we can do this. And with the new road safety strategy and the implementation of the trauma report, there has never been a better time to do this and to do it right. And I firmly believe that we can achieve much more together than individually. And just like the butterfly effect and complexity theory, we too can create a tsunami of change if we choose to. And I'm ready if you are. So I would like to sincerely thank Ashley O'Keefe, who's a second-year medical student at UCD, who did all the data abstraction, Natasha and Shona, the data coders at the NRH, Prasanth Sukumar at UCD for statistical analysis, Michael Kincaid at the hospital for helping me with the SPC. Without them, this work wouldn't have been possible. And I would also like to thank Dr. Conor Deasy and Louise Brent at NOCA and Rory O'Reilly, Data Analytics Healthcare Pricing Offices at the HSE, for their help and information. So it has been my pleasure to share my thoughts with you today. And if you're interested in finding out more, please contact me on Twitter at Áine M. Carroll or by email anya.carroll@ucd.ie. Thank you very much, and I look forward to any questions that you might have. Thank you.